Out loud. So welcome. Welcome everybody in the afternoon session on the symposium organized around the Renal Lifecycle trial. Welcome again. Initially I intended to say on behalf of the Renal Lifecycle trial team, but you all are the Renal Lifecycle team, so welcome on behalf of yourself. As you know, these are exciting times in nephrology for a couple of reasons. So there are a lot of developments, also in primary glomerular diseases, but also in CKD. And up until a few years ago, we had hardly any novel developments in the treatment of CKD, but we do have now. And one of these are SGLT2 inhibitors, as you know, and this is what the Renal Lifecycle trial is about, but there are more developments ongoing. And in the coming 3 sessions, I'm happy to introduce, together with Jeroen van der Net, to chair the sessions in which we have 3 important topics on CKD management. And the first one will be focused on the Renal Lifecycle trial, and our presenter is the chair of the steering committee, which is Ron Gansevoort. Ron, welcome, and the floor is yours.
Thank you, and wonderful that you all are present here, because it's a kind of last-minute symposium. And we hope to have a session on the Nederlandse Nefrologiedagen, but the Nederlandse Nefrologiedagen didn't take place this year, and then we decided at the same week to have this symposium dedicated to the Renal Lifecycle trial, to share our experiences, but also more around it, how to protect the heart and kidneys in patients, especially with advanced CKD. But I'll start with the rationale, recent protocol changes and the first experiences of the Renal Lifecycle trial. These are my conflicts of interest. And I'll give a short introduction. Some of this was already mentioned during the morning. And many of you know, but you always have to start basically. SGLT2 inhibitors, rather old drugs that people often don't know. They are already marketed since 2012 as glucose-lowering drugs. That also means that patents run off in due time. Next year, the year thereafter, many of these drugs will be off patent and become cheaper, is expected. Later, these drugs appeared not to only lower glucose, but also to prevent the heart and the kidneys. Strong renal and cardioprotective effects, and the effects were present in patients with chronic kidney disease with and without diabetes, in patients with and without ACE inhibitors, with and without GLP-1 analogs, I learned recently. So independent effect and really a step forward. But should all patients already be prescribed these drugs? In this slide that I have of Hiddo, the SGLT2 inhibitor trials are positioned. And what you can see in this slide, that there were 3 cardiovascular outcome trials, the EMPERAC outcome trial, the CANVAS trial, the declared TIMI 58. These were especially in patients with normal kidney function, normal albuminuria, but there were also people with slightly impaired kidney function, slightly increased albuminuria. And then we've got the 3 renal trials, CREDENCE, only in diabetic kidney disease, DAPA-CKD in patients with diabetic and non-diabetic nephropathy, and EMPA-KIDNEY again in patients with diabetic and non-diabetic kidney disease. These 3 renal trials differed insofar that the lower threshold for GFR to include patients was first 30 in CREDENCE, then 25 in DAPA-CKD, and it has now been lowered to 20 in the EMPA-KIDNEY trial. In our Renal Lifecycle trial, we include patients with a GFR below 25. KDIGO has now a new guideline that we are allowed to prescribe SGLT2 inhibitors already with an eGFR of 20 and above. These patients can also enter our placebo controlled trial. And we discussed with the steering committee of our trial whether it's ethically justified to have these patients with a GFR between 20 and 25 that can be prescribed SGLT2 inhibitors in clinical care in a placebo-controlled trial. And we said that the evidence in these patients is rather limited, only one trial with a limited number of patients. So we need additional evidence, and we maintain the inclusion criterion on a GFR of 25. But the lower threshold for GFR is important, and that is shown indirectly in this slide. This shows you the mechanism of action of SGLT2 inhibitors. In the proximal tubule, you've got the sodium glucose cotransporter, and this one is inhibited with the SGLT2 inhibitor. And with the SGLT2 inhibitor, you lose more glucose and more sodium in your pre-urine, and in the end, you lose in urine slightly more glucose, so you have glucosuria, and also natriuresis. And that means there is some weight loss, there's some blood pressure control that is better. What is most important, that at the macula densa, it is sensed that there is more glucose and especially more sodium, and then you get tuberoglomerular feedback, a decrease in intraglomerular pressure and a decrease in proteinuria, and that has been suggested to cause the renoprotective effect. But this means that we always assume that the SGLT2 cotransporter is only expressed in the proximal tubule. So you would need proximal tubules for this drug to be effective. But nowadays, more and more studies come forward, experimental studies suggesting that SGLT2 inhibitors can also have effects that are independent of your kidney. And one of these studies I show here, this is a Korean study from 2021. These are mice in which a myocardial infarction was induced. And what you can see is 6 hours. Is this also a pointer? No. No, and on top, it's 6 hours after the myocardial infarction is induced. You don't see any SGLT2 expressed. SGLT2 is red. And then on day 1, you see some redness coming. On day 3 is the maximum, and on day 28, it's gone again. So SGLT2, first thought only to be expressed in the proximal tubule. You can also see it in the myocardium, but only when there is damage. And when you treat these animals with an SGLT2 inhibitor, you see that there's less expression of SGLT2. But when you look at infarct size, and that's the right bottom graph, you also have a smaller infarct size. And these are effects that are independent of kidney function, independent of SGLT2 in your proximal tubule. But there are more studies, and this is a difficult slide, but it is not only about SGLT2 where it is expressed. This is a beautiful finding that when you use SGLT2, your darm content changes. So your microbiome changes, and your microbiome makes less uremic toxins. So when you have less production of uremic toxins, you also have to excrete less uremic toxins. And that's a mechanism independent even of SGLT2 transporter in the kidney, but also in other tissues. It can have also very indirect effects that we never thought of. And that makes that when we think about the mechanism of action of these drugs, we always thought in red it is natriuresis and glucosuria leading to a decrease in intraglomerular pressure and tubular-related effects on the kidney and on the heart, but now in blue and in yellow, that there are also direct effects on the heart and the kidney that cause renal protection and cardioprotection. And that makes that even in patients with very low kidney function or even absent kidney function, these drugs could have beneficial effects. And that is, of course, what we want to test in the Renal Lifecycle trial. And as you know, the Renal Lifecycle trial will include In total, 1,500 to 2,000 patients. We have 3 groups of patients: patients with severely impaired kidney function, GFR below 25, patients on dialysis, and kidney transplant recipients with a kidney function lower than 45. It's a pragmatic trial, limited number of visits for the study, not more than take place in the framework of routine clinical care anyway, and also no more blood withdrawals. Endpoints, a combined cardiovascular renal outcome as usual in this type of trials, but also secondary endpoints that we look at safety, tolerability, quality of life, and cost effectiveness. And now I'll start with the first experiences with our trial. In the Netherlands, there are 67 sites, and as yet 59 have stated that they would like to participate in the trial. 8 declined because there was limited local feasibility for such a study. But 58 participating, although I have to say there are still quite a number of sites that have 0 inclusions, and I hope that we can do better there. But it's not only about the Netherlands. I'm very fortunate that when you start a trial, and it's important in trial, that friends come to help, and friends come from different places. Germany, Würzburg, Professor Christoph Wanner, who works there, has added 15 sites, and Germany will include 250 patients. And I'm very fortunate and happy that Christoph is also here for this symposium. And especially for you, Christoph, we're talking English. Wir können es auch in Deutsch machen, aber my English is better. Australia will help. 13 sites, also around 250 patients. And Belgium will help Dirk Kuipers, the group of Leuven, with 9 additional sites. Here you see overall inclusion. And overall inclusion is in blue. What you see is an increase getting steeper, and during the last couple of months you see now a straight line. And that straight line is composed of the results in the different countries. In red are the Netherlands, in black is Germany, and in green is Australia. And the number of screenings is now 725, which is a great number, I think. The Netherlands has 392, Germany 293, and Australia, starting later, lagging a little bit behind, 38. But 725 is a good number. And when you look at that overall inclusion graph, and when you notice that during the last couple of months is a straight line, you can also extrapolate when we hit the 1,440 patients that, according to the power analysis that we did, that are needed. And then you can see that that is somewhere in Q3 2024. We designed our study with the power analysis that all patients would be included later, that's in the red dot, that would be somewhere in early in 2025. So we are a little bit upfront on what should be done, but that's also necessary. We need that, and I'll explain you why. Here you see inclusion, not overall, but per month and per country. You see that there are now several months that we had a maximum number of 80 screenings per month. And that's now stabilized during the last month. Of course, it was a little bit lower in November, December, the holiday months, but now picking up, and I hope that we can maintain it at around 80 or even increase. The difficulty that will arise here is Germany got money to include 250 patients. They are almost there. So Germany will stop. When Germany stops, you will see that inclusion rates will drop, and that will threaten the overall inclusion rate in our study. But that is why we are now working with especially Belgium, and we hope that according to the new European legislation, we can open up Leuven and the affiliated sites in 2 months from now, that they can take over the role of Germany with inclusion of subjects, and not all sites in Germany will stop with inclusion. Some will continue, especially Tübingen, and I think it's Hamburg. But here you see again that Germany and the Netherlands both are doing a good job. Australia started later, lagging behind, but hopefully also catching up. This is the distribution of the 3 subgroups of patients, and that's the second reason that we have a little bit of a problem and that we should take care how to include patients, is that we have a good number of transplant patients, approximately 1/3, and it should be 1/3, that we have a very good number of patients with chronic kidney disease, 322, but we are lagging behind with dialysis, and dialysis should also be 1/3. And that's the reason that we decided quite recently with our steering committee to change the eligibility criteria, the inclusion criteria of our trial. We first had dialysis patients with a residual diuresis of more than 500 mL per 24 hour, but then we received back the information that most of the dialysis patients don't have that residual diuresis anymore. That's one, and that many of these patients were also a little bit hesitant to collect 24-hour urine. So we make now the collection of 24-hour urines not mandatory, but optional, and it's not an inclusion criterion anymore. So also anuric dialysis patients can now be included, making that our source of dialysis patients is more than doubled now. And I hope that this will be of help. This shows you the withdrawal rate. This is the withdrawal before randomization. So these people have been screened, and to be screened and just before randomization. And then you see that only a very small number falls off during this window. When you look at screen failures, it's only 5.4%, which is extremely low for a clinical trial. And that, I think, is the result that we have limited number of inclusion and exclusion criteria, rather than in most pharmacy trials. And it makes also that the external validity of our trial is quite high, because these are the patients you really see in your outpatient clinic and where we get our results. This is the withdrawal after randomization, so dropout rate. And at the moment, only 17 patients dropped out for various reasons. When you add it up, it's more than 17, but people can have multiple reasons to drop out. But it's extremely low, also much lower than other clinical trials that I know of. This shows you that the drug that we are prescribing is very well tolerated. And that's also that we can use when we are asking patients, would you like to participate in this trial, that we should use, but hardly anybody stops when they start with the trial. Showing you some data of individual centers, first paying tribute to Germany. Germany doing an excellent job with a limited number of centers, but good overall inclusion rate. Hanover doing a very good job. Heilbronn, Charité, Würzburg, where Christoph is working. These are the data for the various regions in the Netherlands. First, UMCG Groningen, then the Albert Schweitzer Hospital, not a university medical center, but a using the word peripheral hospital is never a good term, I think. But also doing an excellent job, and some of the other centers still room to improve. When we look at the top 5 includers in the Netherlands, UMCG Groningen doing quite a good job with 66, also showing that it is doable to include these patients, to include large numbers, but at Albert Schweitzer, Jeroen, my compliments, doing very well. Apeldoorn, a relatively small hospital, but also excellent numbers. Leeuwarden is here with 1 or 2 people, also doing a very well job. Baseline characteristics. These are the first results. Group 1 and Group 2, we don't know what is placebo, we don't know what is active, but what you can see is that the number randomized to Group 1 and Group 2 is nearly similar, but when you look at the patient characteristics, it's also very good balanced. And these are the patients that we see in our clinic. 68% is male. That's probably somewhat more than we see in our clinics, but that's often that you see in clinical trials that males are more likely to participate than females. Elderly subjects, yeah, we had a lot of questions about contraception, but yeah, the people that I have in my trial, contraception is, because of age, hardly any, is not a real issue. Most of them white, but there are some other racial groups. The subgroups I just showed you already, and hemodialysis and peritoneal dialysis, we discussed that this morning. It's the ratio of 3:1. And that means that there's a higher inclusion of peritoneal dialysis, and you already warned we should not over-include peritoneal dialysis, because then you will get a rather skewed impression about the efficacy of the drug in dialysis patients. But yeah, we can always do, of course, subgroup analyses. This is according to the various subgroups. The first column CKD, then dialysis, then transplant patients. And what I expected is true. Transplant patients are slightly younger, of course, than dialysis patients. CKD patients are even slightly older. Sex distribution is not different according to the three groups. Hypertension, the use of RAS inhibitors is not different. What is different is diabetes mellitus. I would have expected higher in transplant because of post-transplant diabetes mellitus, but actually we don't apparently choose patients for a transplant when they have diabetes, because it's actually much lower, the patients with diabetes in the transplant patient. The definition of hypertension, by the way, is either a high blood pressure or the use of blood pressure lowering medication. And sometimes RAS inhibitors are, of course, prescribed to people with normal blood pressure, but to protect the kidneys. So this is a little bit over-exaggeration, I think, of what is really hypertension, but we can't define it otherwise. There have been some protocol developments, what I just told. Dialysis patients with residual diuresis, 500 milliliter per 24 hour, that's not mandatory anymore. 24-hour urine samples, also not mandatory anymore. Screening visit, baseline visit can be combined. That makes it easier for you to include patients, but of course you need approval to use historical data. And there should be very recent historical data, otherwise you can't use them. We have added the cardiac ultrasound and an MRI sub-study. We have added measurement of cognitive function. And the people from the cognitive function test are here. You can do your test. Also important for us, because we need normal values. And it's also very confronting to do this test. But when I compared myself with Helene, I was far less intellectual than Helene was. But I blame it on age. Another thing, the PIF has been changed. Please always use the most recent version. And it's not to an improvement, because, for instance, the German Ethical Board asked for all kind of very detailed information about contraception. And that's now a huge paragraph, and it gives you the impression that you are dealing with a kind of cytotoxic drug with chemotherapy, where it is only a SGLT2 inhibitor. So we should explain it to people when we show them the PIF, that many of these things are mandatory because of administrative reasons, but are not actually a problem. Safety of SGLT2 inhibitors, because that's also what the PIF is warning for. And I think there are important recent data. These are data from meta-analyses of large-scale randomized clinical trials of the 7 trials that have been performed. And when you look at it, there were some initial comments that perhaps there would be more fractures, more amputations, but also more urinary tract infections. And now with 10,000s of subjects in randomized controlled trial, it shows you that there is no increased risk for fractures and not for amputation. So when people have bleeding problems, doorbloedingsproblemen of their limbs, There is no reason not to ask these patients for the trial, because from the meta-analysis, it's not an issue. Urinary tract infections, large portion in the PIV is dedicated to it, but there is in 10,000 of subjects no increased risk. Of course, these were not kidney transplant recipients, these were normal patients, so we are not sure what it will do in kidney transplant patients, but we don't have to be too afraid for it. Genital infections, yes, there is a risk. So Candida, with a number needed to treat during 1 year of 41, I was a little bit impressed by it. And we also checked it in our data. And in the renal lifecycle trial, as yet, with 625 people screened, only one had a genital infection. And perhaps that is explained that we are seeing patients with lower kidney function, so less glycosuria and less chance of Candida infections. But also this is something that you can use to explain your patient when you want to include them. And of course, on the left side are the things that are beneficial. So the number needed to benefit, less acute kidney injury, even less severe hypoglycemia, and of course, less kidney failure, less cardiovascular death, and especially, and that's very important, lower rate of all-cause mortality. And this is one of the very few drugs that has been shown in a clinical trial to have an effect on all-cause mortality. And that is also the reason why people are so enthusiastic about these drugs. Study developments, I showed you protocol developments, these are study developments. We are adding Belgium, hopefully in June 2024. We recently received approval from AstraZeneca for study medication for an additional 500 patients, because the trial is now powered rather meager, rather limited on 1,500 patients, but I would like to have more power and include 2,000 patients. That's going to be difficult, and that's why we are now negotiating with Singapore and Spain, also with networks, that these will also add the trial, both with around 250 patients, so that we can go from 250 to the 2,000 that I would like to include. And we have now a cooperation with some United States sites that we will do a combined pooled analysis in kidney transplant recipients. So they are going probably to do a trial, NIH-sponsored, with 800 patients, we with 500, and then we will have a trial in kidney transplant recipients of 1,300 subjects. Would be the largest transplant trial ever. This is the timeline. We are now in 2024, but the adventure started in 2021. When we received our money, when we received the idea thereafter to do the renal life cycle trial, all patients should be included according to the time frame that we have in mind in Q3 2025, so the third quarter of 2025, and we hope that we have sufficient endpoints in early 2027 to stop the trial and start processing data and analyze these data. So in conclusion, I think we are on track. I showed you the slide with the inclusion rate. We are slightly before what we should do, but there are some difficulties that I anticipate, because some centers in the Netherlands are still not including, and yeah, we need also these centers to include to maintain the inclusion rate in the Netherlands on target. Most centers in Germany will stop including, and we hope to solve this by adding Belgium and potentially adding networks in Singapore and Spain. And inclusion of dialysis patients is lagging slightly behind, but hopefully we can resolve this by deleting that mandatory inclusion criterion of residual diuresis more than 500. And this is my last slide, the acknowledgements. Of course, I would like the participating patients, and I'm also happy that there are some representatives of the Dutch Patient Federation here. There are, of course, many representatives of participating sites, study doctors, research nurses. The steering committee is here, data adjudication committee, I've seen several people, and of course also the patient advisory board. The central study team here, Helene, but also the study doctor and study nurse, Visanne and Yvonne. And last but not least, I also would like the sponsors, and that's the Portman Fund that started this trial by donating 3.3 million euro. And the representatives of the Piet Portman Fund are here in the audience in the last row. So when you would like to talk to them, give them some information, please do. We got also additional money from the Kidney Foundation. The Kidney Foundation, the Nierstichting, arranged everything for us. Australian government added 1.5 million euro for the Australian sites. And AstraZeneca is also important because they delivered study medication. They pay for the German sites and they paid also for the study doctor. And this is my last slide. Thank you for your attention.
Thank you, Ron, for this excellent overview. For me, it's quite reassuring to see that the number of side effects is quite low and the dropout rate is quite low. So I would say for patients, there's no real reason not to be included in this study. But of course, I'm a bit biased. I do have a question myself, but I would like to give the audience the opportunity to ask questions. So I will go around with the microphone. Yeah.
Thank you for the overview. I was wondering, in the CKD population, there was only 76% of patients using RAS inhibitors. And I think it is mandatory unless intolerant. So I think it's a rather large number of patients intolerant to RAS inhibitors. Should we do better is the question.
Yeah. It is first choice therapy, but especially in early stage CKD, many of them are late stage CKD, when you see that ACE inhibitors are stopped again to see whether something happens on residual kidney function, hoping to postpone the start of kidney replacement treatment. There have been some prospective studies that you should not do this because it doesn't help. In contrast, it is not of help, even deleterious, but that might be part of the reason. So some are intolerant, but some it's also stopped by the doctor on purpose. Yeah, and that explains why this is, I think, lower than in many CKD trials.
Can I make an addition to that? But I think your point that we should optimize standard of care is very important, because otherwise the study will be critiqued if the standard of care is not optimal, because the same applies for the use of statins, for instance. And the percentage on hypercholesteremia, you mentioned it was 67, something like that. But actually, we should report on the number on a statin. But your point that we should optimize standard of care is very important.
Yes, a good point. And for the next newsletter to be sent around to all investigators, it would be a point to add there.
Anything to add? Okay. Any other questions? I did have a question about the eGFR drop. As the number one including center, you've included a lot of patients with CKD. And it might worry some patients, of course, when the drop in GFR happens just after starting the trial medication. Is that something you have seen, and to what extent is that drop? Because in the previous trials it was about 3 to 6 mils per minute or so. And you would perhaps think that the drop is a bit lower in our population? Yeah,
I think it is not a drop of 3 to 6 mil per minute, but it's a kind of percentage drop normally. Mm-hmm. But then in our population, you would also expect this, let's say, 6% drop from a GFR from 10 going down. I hardly ever see this, and I think it is because there is so limited glycosuria that your tuberoglomerular feedback in these very late stages of CKD is less important. So actually, in these patients, I haven't seen it occasionally, but then you don't know whether it's just a chance finding or whether it's really drug-related, but on average, it's not much of a problem.
Yeah. No. So that's quite reassuring, and perhaps something we could tell our patients as well. Yeah? Okay.
Maybe in addition to this question you had, some patients hesitate when they are on eGFR of 16 or 18, that their renal function will drop and that they will become a dialysis patient. And then they say, oh, just never change the winning team and this is as it is. But maybe that's something you said already, that we maybe...
this is also something that we learned now. That's what is our experience, and that we should also use when we are asking patients for a trial. And we've got a huge number of subjects included in Groningen, but also a huge number that declined participation. So when we asked them first, they said, yes, I would like to have more information. Then they get that patient-informed consent form, and that is so, it's a terrible piece of paper. But we should guide them through it. But we should also explain it, you are part of a group of patients with a huge mortality. We've got now a drug with hardly any side effects, and it may improve morbidity and mortality. So actually, I would, I'm of course very biased, but I would not see a reason for myself not to participate. And that's, I don't know, we discussed this morning already, what is your experience with asking people for the trial and what their response is? I was a little bit surprised that that refusal rate is higher than I expected. But it's also something about how you inform patients, because Yvonne looks at it, how many patients are asked, and she also sees how many patients are declining, and it's very much doctor dependent. So apparently it is something about the information process that can be of help for inclusion of patients.
Ron, I would like to make a remark and a question to you on the issue that we dropped the requirement for having residual kidney diuresis in people on dialysis. The reason is not only to boost recruitment, of course. The reason also is that we have accumulating data that support that they can benefit as well. But this is a population in which the likelihood of having episodes of dyspnea is higher. So how can we make the distinction between volume overload and heart failure?
Yeah, that's a difficult one, making that distinction. And we should not decide ourselves, because you are all filling in severe adverse event forms. When a patient has volume overload and dyspnea is admitted to hospital, please tick it in the box as a possible endpoint, because we are not to decide whether it's an endpoint. We have got a specific data adjudication committee who will look at all the details of that case, and they will decide whether there is a heart failure component in it. So in case of doubt, always tick the box, possible endpoint. That's an important thing. Thanks for noticing this. Yeah.
Okay. Any other questions? No? I would like to go on with the next speaker then. And I would like to introduce Professor Wanner from Würzburg. He's also a visiting professor at the University of Oxford and the current president of the ERA, the European Renal Association. So we are quite happy that you were able to make it here to give a presentation. He's of course also a member of the steering committee, and that has proven to be a very fruitful collaboration. So thank you.
Yeah, thank you for the invitation. And then I saw the program, and then I wondered what should I talk to you. Yeah, and I also, when I give now my declaration, next one. So this is. This one. Okay. Then I have also to do a declaration that I had some, I think it's the same word in Dutch, angst, to speak after Ron and before Hiddo, because the beautiful data are coming. So I changed the entire concept, and I discuss more, and I think my talk is also an interaction. Somebody can ask questions in between, so let's see how it is going. Yeah. And the talk is, Okay, let's do like this. To overcome the barriers and optimally combine all. But what are all currently available treatments? Yeah? And here are the treatments. Yeah? You should not do, for the younger people, such slides, because don't use so many colors. That's the first rule when you train, because you are distracted by the many colors. But the many colors give us also the beautiful flower bouquet we have today in nephrology. We are using RAS blockade since now 20 years, and we had nothing else. But now, since 3 years, we have the SGLT2 inhibitors with these 3 trials, and this is exciting, but also overwhelming when you look now at pillar number 3, because the next intervention, and now soon we get the next intervention with the flow study, and then we have 4 pillars. So currently, our nephrology colleagues are not used to this, are a little bit overwhelmed. This is my experience. So how we can overcome these barriers and implement these pillars in our patient. And there is another barrier, is the daily costs. So I think when you look through the dollars, this is US. US is a totally different world. There are barriers, are the costs. But in Europe, just 2 days ago, we got for the non-steroidal MRA, we got finerenone, the allowance from the government to spend €2.04 in Germany. So now you get 3 pillars below €5. This is exceptionally, and you can prevent dialysis. So even if we talk about costs in my talk, what usually do not do, now we get 20 cents less than €2, and €2, that's great. Yeah. So how to use all these medications. And then you can go to the next topic with a GLP-1 receptor agonist. We are not yet there, but I think we get the label in 2025. We get now the results at the ERA Congress in Stockholm on May 24. And then we know already what we have heard from the press release, that there is a 24% reduction in the primary endpoint. We know the primary endpoint, and when you stop a trial, every subcomponent of the endpoint is positive. So we get a positive signal for mortality, for cardiovascular outcome. And this is great, and it will go into the guidelines and will give us a label for, I don't know what you pay in the Netherlands, €7, the 4th pillar. And this will be an injection. So you have 3 pills to get into your patients and an injection. And this is the beauty we have today. Finally, we have something. On the other hand, we are shocked and overwhelmed, and we sit there and scratch our heads sometimes. Yeah? So the guidelines already, KDIGO is putting the pillars in the guidelines. You see here in the first-line drug therapy, which is here. No, it doesn't matter. It's statins down there for atherosclerotic cardiovascular disease. It's RAS blockade, mainly for hypertension and retarding progression of chronic kidney disease. SGLT2 inhibitors currently for everything. And metformin. Cardiologists are now fighting metformin. They say there is no evidence. You can put it away. It kills compliance. Let's put GLP-1 receptor agonist, which is on goal-directed therapy, pull it down and replace metformin by GLP-1. Because there is evidence now, and the recent European Society Cardiology guidelines, they already put finerenone as a class 1A recommendation for the treatment of kidney disease, diabetic kidney disease. Yeah. So they are a little bit advanced of the KDIGO guidelines, and GLP-1 receptor agonists, which have a 1B class, will move down with the flow study. And the non-steroidal MRA were recommended by the cardiologist to go into a 1A for treatment of kidney disease, and they will also move down. So we have these 4 pillars in the first-line drug therapy when these guidelines will be revised. That's my prediction or guess. Yeah, I hope it's true. You can protest. So how to optimally combine? Yeah? My proposal is we do need more than only 1 or 2 pillars. We need all 4 pillars. Some patients can beautifully be stabilized on SGLT2 inhibitor, optimal blood pressure, target. I can do miracles today, but not everybody. Yeah? Some patients need more, and they need all 4 pillars. And the question is, don't waste time. Yeah? We are sitting there, we ask our patients first come back. He doesn't come back after 3 months, and after 6 months he's coming back. We observe the effect of the first treatment, and the patient has 3 more problems to present. We do not want to introduce the second pillar, and therefore we lose time and GFR drops until we wake up. Yeah? So this is an issue today. Don't waste time. My question to you is, should we now use all 4 pillars and all in 3 months? The cardiologist with their heart failure medication, they say all in 4 weeks. Nephrologists are not prepared to bring all in because of uncertainties. So therefore, I'm putting here up 3 months. I wonder what you are saying. Nephrologists hesitate because they now do 3 ml drop by SGLT2, another 3 ml by non-steroidal MRA. We wonder what GLP-1 receptor agonists do, and they add 3 ml, 4 ml, another 3 ml, and then they have acute kidney injury. Yeah? We have no data there, but these are the hesitations. Yeah? So I think we need a trial, an implementation trial. With all in 3 months. So a bit controversial maybe today, but I decided to talk with these new things to you. A good sequence is how to optimally combine, according to me. All patients already have RASI. 76% I heard. I congratulate you, the Netherlands. Germany is at 68. Yeah. The New England Journal paper from yesterday told us that the United States are also with RASI saturation at 65%. So we can see across the world how good we are, but we will never reach 100% by some reasons. So so they come in with an RASI, and then you put an SGLT2 inhibitor on top, and then you give a non-steroidal. I think this is an optimal combination because not because SGLT2 inhibitors are superior to non-steroidal MRA, but Hiddo published that the potassium signal may be lower. There is some risk to having increased potassium. With an SGLT2 inhibitor, you blunt this signal a little bit. Yeah? And therefore, I think it's an optimal combination. A trial is out there, is coming, whether with a combination and active, whether we can see it then. And SGLT2 inhibitors, according to my feeling, are not superior than non-steroidal MRA. They are a different class. They are hemodynamically active. Non-steroidal are working in the long follow-up, antifibrotic. So they have different mode of action. And then we have the next thing. What about newcomers is a question I got. I get a patient, has nothing, first time diagnosed. Actually, I had now one. After so many years, he came to me, diagnosed, newcomer, and I tried the new concept. I gave him first an SGLT2 inhibitor. 2 weeks later, I had to give him a RASI inhibitor because of hypertensive episodes. But why not? Yeah? So you do not need to follow a certain sequence. Yeah? why not adding GLP-1 receptor agonist at any time? I think there are some specialists which have a preference. The one specialist, the endocrinologist, look at high body mass index and say, now this is my indication. Yeah, I discussed with Hiddo the personalized medicine, which means that the big packages need GLP-1. Yeah. The Japanese people, they will not use, they are slim, they have a little bit of a belly, and they have a diabetes, and they will use not GLP-1 receptor agonist at a body mass index of 20. That's my guess. A big discussion will coming on. Then the adherence and compliance. Today I use a polypill. And we have in Germany, we have polypills. They are composed of a RASI, a calcium channel blocker, and a statin. We also have RASI hydrochlorothiazide. And I put them together that I can bring the other medication into the patients, because they always tell me, doctor, I don't take so many pills. Maximum is 7. Or so, yeah, everybody is different. And then I put them together. Can I combine it? And it takes time, 3 months. So these are my suggestions to optimally combine clinical one. To overcome barriers. I hear always, I do not use these new treatments unless I do not know how they work. Yeah. Typical nephrology answer, physiology-based. The cardiologist is saying to me, I don't care how they work, if they work. Yeah. So I follow guidelines. Before the treatment, there should be a diagnosis. This is another thing. Yeah. And we are not very good out of nephrology to make a diagnosis. Yeah. Look at the heat map of KDIGO and look at A, albuminuria, and E. We nephrologists do not see patients in the blue box. They have normal kidney function. They are healthy. If you don't do albuminuria, UACR, then you can discover some people with early incipient kidney function. So I think this is something, the elephant in the room. Yeah? And when I had recently a lecture to general practitioners, yeah? And I always get the similar questions. Yeah? They do not measure UACR, yeah? And they ask the 5 Ws, when, where, what, who. Maybe you can answer these questions to me. The first is, when do I sample? Yeah, clear for us nephrologists. Yeah. Where to send and how? This is the question of a general practitioner. And always, what does it cost? Yeah. And who pays? And what does it mean? For me, milligram per gram, UACR, no, I have no feeling about it. Yeah. So what is the answer? What you have to give as a specialist to our colleagues out there. Yeah. So morning spot urine, yeah. Is it the same in the afternoon? My patients are coming in the afternoon. Can I sample? These are the questions there. The central lab together with the blood, a morning, yeah, when? The first morning, second morning, and so on. In Germany currently is €3.40. In the big laboratories, and it's standardized across Germany, people do not know what it costs. And there are assumptions out there. And it's not less and not more. Some people say it's too expensive. Then insurance pays. Yeah, the sick insurances in Germany are paying. It goes from the budget the doctor has, and the doctor has budget. And some want to save money because they get something back, and therefore they don't do UACR. And others, they don't care. Because if you go over the budget, nothing happens in the moment. Yeah? That's interesting. Yeah? And what does it mean? I draw this train. I don't know whether you can see it. GFR, you know where the patient is in his life. If you measure UACR, you know how fast the train is traveling to the cliff. And this is milligram per gram UACR, high speed to the cliff. This is this is student level. I didn't know whether I should present it to you, yeah. But this is the reality out with our colleagues, and we have to answer these simple questions to them. The broad label currently, SGLT2 inhibitor into the drinking water. Doctors do not like these questions because it's suspicious. If we have these new medications, every 10 years we have a new one and it's always the same. And later on, but we have now 90,000 patients in randomized controlled trials. Ron has showed this slide, and we do not expect more surprises with 90,000 patients randomized. Yeah, we never had this huge number of good trials in the early days. Yeah. And one comment about the GFR. We are not allowed to give every SGLT2 inhibitor, I would say, because if AstraZeneca is hearing this, they say, no, we have the label only to 25. And only the KDIGO people recommend this based on, yeah, of course, empagliflozin. They went down to 20 with their trials. AstraZeneca, don't know why they decided, but it is very logic when we look across our data that also dapagliflozin works down to 20. Yeah, so therefore, KDIGO doesn't want to make these differences because it makes it too difficult. And therefore, I think recommendation is, and I don't get any lawyer when I use dapagliflozin at GFR of 22. Nobody's coming. I don't know. That's my comment. Please, and then now there are the remaining question with SGLT2 inhibitors. Yeah. So here are, can or could we also treat patients at old age? My patients are all at 85 years, yeah, and they are all frail. We did an analysis now, and the paper is submitted. Frail people in EMPA-REG outcome benefited with the same rate. So frailty, the data will come. Are the benefits of SGLT2 inhibitors explained through muscle wasting? Yeah, when you shrink the patients, they lose 3 kilograms. Is it muscle? Is it fat mass? And maybe if you lose muscle mass, your drop in creatinine is a different one. And there is so many suspicious things out. We did cystatin C and ruled out any problems with muscle wasting during SGLT2 inhibitor treatment. And I think, Hiddo, you have so many data, you will not show these, cystatin C, but I think this is ruling out the muscle wasting issue. How early should we treat to prevent CKD? We do not see patients so early on. We see late. So now some nephrologists say this is the job for primary care. I don't know how you discuss this. And then there are some pertinent, sometimes annoying questions. They ask me, can we give it to CKD5, hemodialysis, transplant? And I always say, come on, get involved, go into renal life cycle trial, yeah, and put the people in the trial, and then you know the answer. Yeah. So actually, yeah, and type 1 diabetes, you cannot recommend, some do it. Urinary tract infection is not the issue, it's genital infection. And ADPKD, there may be trials which are coming. Yeah. I heard that Japan is preparing a trial. In Germany, they asked the government for a trial. So let's see. The CKD5, my experience in the renal life cycle trial is these patients can only be treated by nephrologists because there is so many things going on with these patients, and they have muscle aching and cramps, and when they get a new medication, they come back to you and say, this is the medication, I don't want it anymore. So there are so many things, and these are not side effects of SGLT2 inhibitor treatment. So nephrologists can cope this. Yeah? And then just 5 final minutes where we are going with our thinking. We do not want to retard progression, we want to maintain kidney health. And maintain kidney health, what does it mean? It means that you stay within these borders with kidney function and give SGLT2 inhibitor to people with normal kidney function. something very strange, but could be discussed when you look at empiric outcome. This is the placebo distribution, and these people in empiric outcome, they lost 1.8 ml per minute per year. These were cardiovascular diseased patients. If you look at the curve under empagliflozin, everybody is shifting to the right. Yeah, the entire group is shifting to right, down to a loss of 0.3. This is below the age loss of kidney function. So interesting. So if you look at normal albuminuric patients, you can understand that you need to wait 20 years. So why giving an SGLT2 inhibitor to normal kidney function and no albuminuria? This is currently a big debate. But there was, I think, a discussion at KDIGO defining individual at risk, and the discussion was in Rome, November 30 to December 3, on maintaining kidney health. And this group identified some people where early SGLT2 or early optimal treatment may be of help. And this is the list, and I think is my final slide. Takes half of a minute. There are 3 categories which define early risk: metabolic, familial, and environmental diseases. And you can see the first line is type 2 diabetes, morbid obesity, and then pre-diabetes. When they go towards diabetes, gestational diabetes, where the risk is high, maybe we should treat distinct people earlier with an SGLT2 inhibitor, because they have the risk with gout and arthritis, with the metabolic imprinting of their children intrauterine. And then we have CKD in families. We can draw family trees, and prevent diseases, specific diseases. High pressure, blood pressure, preeclampsia, and some ethnic minorities. Several things which will come in the future is the environment, the toxins, the changing climate will hit the kidney, and the demographic change. We all get older, and kidneys in some people will not live forever. And some others. So these are the risk groups for kidney disease, and maybe should be treated earlier with one of the strategies we have now in hands, and to optimal treat these patients. I think for every trial you need a team, and actually this is my final trial, my final slide. Every trial needs a soul. And this is the team of the Renal Lifecycle trial and of other trials in Würzburg. And when you have a team and they like each other, and I cannot motivate males anymore for trials, I don't know why, because maybe the job is so attractive for women because they can work from home, they can come an hour later, can bring children to kindergarten, and therefore this is the team in Würzburg, and we are so successful, Ron, because there is a soul in our trials. Always you need a soul, and then you have the soul, the mood. People in your network, when you telephone with them, they feel this, and then they work and take another effort. Okay, so that was everything. Thank you.
Thank you, Christoph. You didn't mention it, but in the trial so far, the numbers needed to treat are excellent, also on cost perspectives. But this may change if we push the indications into putting it into the drinking water. Can you comment on that?
Yeah, 19 in the DAPA CKD trial, 20-something empakidney, 40 with finerenone are beautiful numbers. You go over 100 if you treat these people at risk. Also, I think we cannot do trials or different trials where we use maybe slopes in the future, yeah, to prove which is at risk and to distill the patients. I understand that you spend a lot of money and it's not cost effective in these people, but if you can prevent the disease, this is currently under discussion. Yeah.
Thank you.
Thanks. Critical question, yeah.
That's my role.
Yeah, great presentation again, Christoph. You had one very provocative slide, and perhaps you could show it again, because I think that is the pivotal slide to be discussed today. And that's when to start which drug. And you said, perhaps we should start with an SGLT2 inhibitor. But in my experience, I have seen patients with 8 grams of proteinuria and rapid renal function decline. And I started an ACE inhibitor, and proteinuria went down to less than 0.5 gram per day, and a complete stabilization of kidney function. And that is so overtuigend, convincing, that's the right word. I don't need a trial with ACE inhibitors. SGLT2 inhibitors are good on average, but I've never seen such a dramatic response. My experience is still limited with SGLT2 inhibitors, so I should be careful, but that's for me the reason that I always start first with a RAS inhibitor. We always prescribe a sodium-restricted diet, and I thought we should add a diuretic. And the diuretic now is, for me, the change from hydrochlorothiazide to an MRA, because it's a diuretic, but it has also anti-proteinuric renoprotective efficacy in itself. And then I add the SGLT2, but now I'm a little bit hesitating because an SGLT2 is also a little bit of a diuretic. So perhaps, is it now an MRA, second place after the ACE inhibitor, or is it the MRA? And that's for you, but also perhaps for the audience, what their opinion is there.
I also saw these beautiful reactions to RAS inhibitor on 8 gram. I also looked at the 60 nephrotic patients in EMPA-REG outcome. You can achieve a 50% decline with the SGLT2 inhibitor from 8 to 4 gram. You bring these people out of a danger zone. Yeah. So I expect your proposal. It was a bit provocative to also change a little bit the frame, and I committed that I had 2 weeks later the RAS inhibitor on board. Yeah. But this is the entire frame we are discussing, but don't lose time, and one after another in a sequence in a short period of time. And RAS inhibitor, okay. Yeah.
Anyone else? I'd like to make another comment, which is not so critical. I like the concept of kidney health, because probably GFR might not be the optimal reflection of kidney health. Because in my perspective, if GFR drops after initiating SGLT2 inhibitors, actually have unmasked hyperfiltration, right? Mm-hmm. So I like the concept of kidney health and not be too afraid of some drop in GFR. Anybody else? Well, if not, then we proceed. Thank you very much, Christoph, again. Well, we just heard that there was angst to hear Hiddo. We look forward to it. Hiddo, you hardly need any introduction, and we look forward to hear your overview on current and also future renoprotective treatments for CKD, which is an epidemic upcoming, so we really need novel treatments and possibly combinations of them as well. So Hiddo.
Yeah, thank you, Mark, and thank you, organizers. And there should be no angst. There should only be excitement, and because it is very exciting what's going on. A couple of years ago, we were all sad, and we said, well, another failed trial, and there's no new drug. And nowadays, we stop the trials early for overwhelming efficacy. So we are completely at the other end of the spectrum. namely only positive trials, and that creates a lot of positivism, but also a lot of questions. I'm going to give you a look towards the future and tell you what's going on in the field of new therapeutics for chronic kidney disease. And then the question is further optimization possible, and for whom? And I think that touches upon the question that Christoph also mentioned. Should we start treatment in all these patients together, or should we be smart and think about the right combination for the right patient? So until the late 90s, we had the ACE inhibitors and angiotensin receptor blockers, and some people started to already think about personalized medicine. But if you look at it from a perspective today, it's of course a little strange because we had only one drug. How can you personalize one single drug? It would have been much nicer if you have a menu of multiple drugs that you can use to personalize medicine and to think about the right patient with the right drug. And nowadays we are in that position because we have a lot of new interventions for the treatment of chronic kidney disease. And I've mentioned here, listed here since 2000, a couple of them, and Christoph already mentioned them, the SGLT2 inhibitors, finerenone. We've heard about the FLOW study already. That's a trial with semaglutide that was stopped also early for overwhelming efficacy. And in patients with non-diabetic kidney disease, we see that SGLT2 inhibitors are effective, but also endothelin receptor antagonists that are tested, for example, in the DUPLEX, the PROTECT, and ALIGN clinical trial. So this is an overview of the SGLT2 trials, 3 dedicated kidney outcome trials that have been conducted. The first one 5 years ago in diabetic kidney disease, and then the 2 other ones, DAPA-CKD and PAKidney, in a broad population of patients with and without diabetes and chronic kidney disease. And all these trials consistently demonstrated the benefit, leading to changes in the guideline now recommending SGLT2 inhibitors, as you can see in the bottom. SGLT2 inhibitors, as we know, reduce albuminuria, and they do that very nicely. You can see that here on the left. For example, in the CREDENCE trial, they reduce albuminuria by about 30%. Does then every patient benefit with a 30% reduction in albuminuria? Well, probably not, and there are still a number of patients who have, despite an SGLT2 inhibitor, still very high albuminuria levels. And you can see that in the slide on the right. The solid bars indicate the number of patients in a certain albuminuria category at baseline. And as you can see, for example, if you look at the second solid bar, an albuminuria level between 300 and 1,000, in the CREDENCE trial there were 825 of such patients. Then the striped bars indicate the number of patients in these albuminuria categories after 6 months. And what you can see on the right side of the graph is that there are still more than 800 patients with an albuminuria level more than 1,000 milligram per gram. So these patients still have high albuminuria, despite receiving an SGLT2 inhibitor. And that high albuminuria, that is predicting the rate of kidney disease progression, also during SGLT2 inhibition. And you can see that here in the graph, on the left for kidney outcomes. And the black circles are the canagliflozin-treated patients, and the white circles are the placebo-treated patients. If you take a patient, for example, with an albuminuria level between 1,000 and 3,000, that patient has a higher risk than a patient with a lower albuminuria level. But that patient has exactly the same risk as a placebo-treated patient. So it is not the SGLT2 inhibitor that is dictating the risk for progression. It is the remaining albuminuria level during SGLT2 inhibition that predicts the outcome. The only difference between the placebo and the SGLT2 treated patient is that the SGLT2 treated patient started with an albuminuria level of about 1,500, was reduced by 30% to 1,000, and that 1,000 has the same risk as a placebo treated patient who started with 1,000, didn't change albuminuria, and stayed at 1,000. If that is true, then we should think that we should lower albuminuria even when you have an SGLT2 inhibitor. And that is the rationale to test new medications on top of SGLT2 inhibitors. And we have such drugs. We have finerenone, the mineralocorticoid receptor antagonist, and we have the endothelin receptor antagonist. And these drugs work through different modes of action, so potentially you could combine them and they target different pathways in the pathophysiology of chronic kidney disease. Well, what do we know about the combination of these treatments? Let's first take a step back and let's look at the effects of SGLT2 inhibition on hyperkalemia. It turned out that when we looked at these in these past clinical trials, you can see that SGLT2 inhibitors reduce the risk of hyperkalemia. This was first demonstrated in the EMPA-REC outcome trial, shown here. Then later on, in the CANVAS trial, although not statistically significant. Then in patients with diabetic kidney disease, in the CREDENCE trial, SGLT2 inhibition reduces the risk of hyperkalemia. And then in patients with heart failure, you see a similar direction that SGLT2 inhibition reduces hyperkalemia. How is that possible? I think they reduce the charge potential in the distal lumen, and that drives potassium excretion through the epithelial cells. That has clinical consequences. Not only the reduction in hyperkalemia, but patients can tolerate the RAS inhibitor that they use for a longer period of time. This is a publication that was published end of last year in the Journal of the American Society of Nephrology, where we looked at the discontinuation of the ACE inhibitor or angiotensin receptor blocker. And what you can see in the CREDENCE trial is that in the placebo group, there were more patients who discontinued the ACE inhibitor or angiotensin receptor blocker over time. And the same was true in the DAPA-CKD trial. Effect sizes were similar, and if you combine the two trials, you see a statistically significant treatment effect. That is useful for patients and could perhaps be one of the mechanisms of protection of an SGLT2 inhibitor, because you can tolerate proven effective kidney medication better in the presence of an SGLT2 inhibitor. But it has also consequences for future trials. Because maybe we can combine an SGLT2 inhibitor with a mineralocorticoid receptor antagonist to further reduce albuminuria, to maximize the protection, but at the same time mitigate the risk of hyperkalemia induced by an MRA. So we designed this study. This was an investigator-initiated study already a couple of years ago in 2017, where we didn't know actually a lot about hyperkalemia. We only wanted to look at albuminuria and blood pressure, but now it's nice and interesting to look also at the combination of eplerenone with dapagliflozin on hyperkalemia. And we published this last year, and we demonstrated that in these patients with chronic kidney disease who had high albuminuria levels, around 0.5 gram per day, dapagliflozin reduces the albuminuria level by about 19%. And eplerenone, 50 milligram per day, reduced it by 34%. And 19 plus 34 is 53%. And you can see that the combination reduces albuminuria by 53%. So the two drugs, potentially working through different mechanisms of actions, add to each other, and you can achieve a more than 50% reduction in albuminuria. What you can also achieve with the combination is a further reduction in blood pressure, shown on the left, 4 millimeter mercury with the mono agents, 10 millimeter mercury with the combination, and eplerenone increased in potassium 0.4 millimole per liter on average in this study, but that increase in potassium was reduced by the addition of dapagliflozin to 0.2. When we looked at side effects as reported by the investigators in this study, and we looked at hyperkalemia in the middle, 8 patients on eplerenone experienced hyperkalemia, and only 2 with the combination. If we looked at the number of patients with a potassium value of more than 5 millimole per liter during the study, 12 on eplerenone and 5 on the combination. So you have a combination of medications that maximizes the protection, further reduction in albuminuria, and less side effects. And that finding is now replicated in a much larger study, the CONFIDENCE study, which is currently ongoing and uses 3 treatment arms, finerenone and empagliflozin, finerenone alone or empagliflozin alone. There's also another study that is going to start in next weeks. It's the MERO-CKD study that uses a novel mineralocorticoid receptor antagonist, balcinrenone, in combination with dapagliflozin. So it's one tablet where you get that combination, and that combination is tested against dapagliflozin alone. So I think you'll see more of these combinations in the future. Now, eplerenone, or mineralocorticoid receptor antagonist, work through the cytosolic mineralocorticoid receptor. So it's in the nucleus where they act. But there are also so-called non-genomic effects of aldosterone. We think that aldosterone can bind to other receptors and then causes inflammation or fibrosis. So can we block aldosterone in a different way? And yes, that's nowadays possible. We can block the aldosterone synthase enzyme. If we look at the production of aldosterone, we have a precursor, 11-deoxycorticosterone, and that is converted to aldosterone by an enzyme called CYP11B2. If you block that enzyme, CYP11B2, with the aldosterone synthase inhibitor, you can reduce the concentration of aldosterone in the blood and thereby, hopefully in the long term, protect the heart and the kidney. But there's one potential downside, namely you need a very specific aldosterone synthase inhibitor, because there's another enzyme, CYP11B1, that is responsible for the production of cortisol. And we don't want to block the production of cortisol. Well, the initial aldosterone synthase inhibitors were not so specific for the aldosterone synthase inhibitor, and they had a profound effect on the production of cortisol that could lead to adrenal insufficiency, and that's something that we want to prevent. Nowadays, there are very specific aldosterone synthase inhibitors, and these are much more selective for CYP11B2 compared to CYP11B1. And one of them is baxdrostat. Baxdrostat reduces blood pressure, as demonstrated in this study, in patients with resistant hypertension by about 8 to 11 millimeter mercury at a dose of 1 to 2 milligram. Baxdrostat in this study also reduced albuminuria by about 30%, but just like the mineralocorticoid receptor antagonist, this drug also increases hyperkalemia. So we still have that same problem that we try to prevent hyperkalemia. So for the future, can we think about a fixed dose combination of this molecule together with dapagliflozin to reduce the hyperkalemia, but still maximize the blood pressure reduction and albuminuria reduction? Well, there's another aldosterone synthase inhibitor in development. These data were presented only a few months ago at the American Society of Nephrology with a new aldosterone synthase inhibitor. And as you can see, this drug, in combination with empagliflozin, at a dose of 10 milligram, reduced albuminuria by 46%. So these drugs are very potent in reducing albuminuria. They also reduce GFR, so you have acute reductions in GFR, just like with the SGLT2 inhibitor. For example, if you look at the slide on the right, you see that empagliflozin alone, in the first weeks, empagliflozin run-in, reduces GFR by about 4 mils per minute, and then you get another 4 mils per minute further reduction in GFR. That is on average 8 mils per minute. That's quite a lot, and that is something that we have to be aware of if we start to combine these medications, that we see a big acute dip in GFR. But this drug, just like the other aldosterone synthase inhibitors, increase hyperkalemia as well. And this is the trial I was just talking about or alluding to. This is a new clinical trial, Arctic study, that is testing a fixed dose combination. So again, it's one tablet of a SGLT2 inhibitor, dapagliflozin, together with the aldosterone synthase inhibitor, baxdrostat, for the prevention of chronic kidney disease progression. So we have one tablet, 2 targets, and we hope that with that two targets will further reduce albuminuria, slow the progression, but also reduce the risk of hyperkalemia. And in this trial, we test that against an SGLT2 inhibitor alone. This trial just started last week and will enroll 2,500 patients. And this is a nice overview if you are interested in the differences between the mineralocorticoid receptor antagonists versus the aldosterone synthase inhibitors. They both block aldosterone, but they have some different effects, and I found this a very nice review published at the end of 2023 in the New England Journal of Medicine. Now, what about other medications? I already mentioned the endothelin receptor antagonists. They also have very profound kidney protective effects. That was first demonstrated in 2019 in the SONAR trial. As you can see on the left, you see a reduction in the risk of kidney failure by 35% if you treat patients with a low-dose specific endothelin receptor antagonist. However, these drugs have a side effect. They cause fluid retention, and in some patients that leads to heart failure. Despite all the precautionary measures that were taken in this study, you can see on the right that there is still an increased risk of heart failure, although not statistically significant, with this drug atrasentan. But now we can again think about a combination with an SGLT2 inhibitor, because Ron already mentioned, well, I see SGLT2 inhibitors may have a diuretic effect. Could we combine a diuretic with an endothelin receptor antagonist to maximize protection and at the same time reduce the risk of fluid retention? In this study, the SONAR trial, although it was against the protocol, there were some patients who started an SGLT2 inhibitor at the same time when they started atrasentan. And as you can see on the left, if you look at body weight as a proxy for fluid retention, you see in the blue bar that those patients who started atrasentan and the SGLT2 inhibitor had a reduction in body weight, so perhaps less fluid retention, whereas the patients who started atrasentan alone had an increase in body weight, so more fluid retention. And on the right, you see that the combination had more albuminuria reduction. This led to a prospective phase 2 study with a fixed dose combination of an endothelin receptor antagonist in combination with an SGLT2 inhibitor. And these data were also presented at the end of last year. And what you can see in the blue and green line, that is the combination zibotentan, a low-dose endothelin receptor antagonist, together with an SGLT2 inhibitor, about 55% reduction in albuminuria, more than dapagliflozin alone, which led to a 28% reduction in albuminuria. But the question is, of course, if we look at the side effects, can we mitigate the fluid retention by the addition of a diuretic, dapagliflozin? So in this study, we measured with extracellular fluid measures, total body water, extracellular fluid volume, intracellular volume. And what you can see is that the low dose, only 0.25 milligrams zibotentan, the blue line, there's no increase in fluid retention, no increase in total body water, no increase in extracellular volume or intracellular volume, whereas with the higher dose, you see these increases. Well, nowadays we do this trial, it's already underway. Many patients are already randomized into this study. It's the Zenith study, where we test the long-term effect of this fixed dose combination, zibotentan in combination with dapagliflozin compared to dapagliflozin alone. It tested 2 doses. If you have a higher GFR, you get the high-dose zibotentan. Oh, this is going automatically. And if you have a lower GFR, you get a very low-dose zibotentan to mitigate the risk of fluid retention. And then finally, the GLP-1 receptor agonists, they can protect the kidneys through direct effects or indirect effects. Indirect effects by improving glycemic control, blood pressure control, body weight control. But perhaps these drugs also have direct effects on the kidney, such as natriuretic effects or hemodynamic effects or improvements in endothelial function. We heard about the FLOW trial, which was a clinical trial in patients with diabetic kidney disease, and the trial will be presented next month at the European Renal Meeting. What I found interesting to read in the press release was this last sentence, namely that semaglutide confirmed the secondary endpoints, and the secondary endpoints were all-cause mortality and GFR decline. So this drug also reduces the risk of all-cause mortality. We don't know by what degree, but we'll see that next month. But there's a big development in the world of the incretins. First of all, we can combine an incretin with an SGLT2 inhibitor. This is a very small study from Amsterdam that looked at the combination of exenatide, a GLP-1 receptor agonist, together with dapagliflozin. And if we look at 24-hour albuminuria in the blue bars, you see that with the combination you get further albuminuria reduction compared to the use of the single agents. But there's, as I mentioned, there are newer incretins. Nowadays, combinations of different incretins are developed. For example, GLP-1 and GIP. GIP is the other incretin hormone that is responsible for releasing insulin and also satiety effects, and also delaying the emptying of the stomach. And if you have the combination of GIP together with GLP-1, maybe you can further protect the kidney. That was tested in this study that looked at the effect of tirzepatide, the GLP-1 GIP receptor agonist, versus insulin treatment. And if we look at albuminuria over time in these patients with type 2 diabetes at high cardiovascular risk, you see that in the blue line, the tirzepatide group, the albuminuria levels decreased over time, whereas in the insulin group, the albuminuria levels increased. If you then stop the drug, and you see that here at the far right end, you see that during the washout phase, the albuminuria levels in the tirzepatide group increase again, indicating that this initial reduction in albuminuria is probably a true pharmacologic effect. But more interestingly, if you look at GFR decline with this drug, you see that just like we've seen with the ACE inhibitors, SGLT2 inhibitors, this drug tirzepatide also causes an acute reduction in GFR, seen over the first 12 weeks, and then more or less stabilization of the kidney function over time. If you stop the drug in the blue bars, the blue squares at the far end right, you see that the GFR increases a little bit again, suggesting that perhaps part of this initial reduction in GFR is reversible, reflecting a hemodynamic effect, what we've seen with SGLT2 inhibitors as well. And these drugs are equally effective in reducing albuminuria or slowing the progression in patients using an SGLT2 inhibitor or not using an SGLT2 inhibitor. For example, if you look at albuminuria on the left, yes is SGLT2 inhibitor, no is no SGLT2 inhibitor. Similar effects. If you look at GFR decline and the slowing of GFR decline, it's a similar effect. So I expect that in the near future you will hear much more about tirzepatide and kidney studies. But it's not only tirzepatide. Nowadays we also have combinations of GLP-1 with glucagon. And this is another study, cotadutide, which is a so-called glucagon GLP-1 combination. And that combination, as shown here in the bars, reduces albuminuria perhaps even more than GLP-1 alone. So there are many, many of these combinations in development for protection of the kidney. The trials are only now phase 2 trials, but I predict that in the next year there are many big outcome studies starting. So what do we do then? How can we do that? How can we go in with all these medications, target the right combination of these drugs to the right patient? Well, for example, this is my algorithm for personalized medicine. It's my last slide. An obese individual with a very high HbA1c and a low kidney function, perhaps you should treat that individual with SGLT2 and GLP-1. But somebody else, with heart failure, that patient could benefit from an SGLT2 inhibitor together with a mineralocorticoid receptor antagonist. But somebody else, a patient with high potassium who you cannot treat with a mineralocorticoid receptor antagonist, maybe that patient can benefit from an SGLT2 plus an endothelin receptor antagonist. This is my simple algorithm, and I'm sure that in the future we're going to develop new biomarkers and can really target it. But I think that we should have to start somewhere, and this is my idea. So, new combinations of treatments for patients with chronic kidney disease are in development. And these therapies target different pathophysiological drivers of CKD progression. And the challenge for the future is finding the right combination for the right patient. Thank you for your attention.
Yeah, thank you for your excellent presentation. And yeah, it's very, as you already said, it's indeed a very exciting era to live in terms of the new renoprotective medication. It's really nice to see your enthusiasm being at the forefront of all those developments. I had a question about the aldosterone synthase inhibitors, and I was wondering, because they work in the same pathway as the MRAs, would that make the MRAs obsolete or not necessary anymore, or is there still room for synergistic effects with those two drugs?
It would be interesting to see if you can combine the two, a blocker with a synthase inhibitor, because the blocker still allows the aldosterone to target the receptors, the non-genomic receptors, which you can block with aldosterone synthase inhibitors. I'm not saying we should do this because we have the experience of combining an ACE inhibitor with an angiotensin receptor blocker, and that was not such a success. So where is the place in the treatment for the mineralocorticoid receptor blockers and the aldosterone synthase inhibitors? I actually, if I'm honest, I don't know. I have the impression that the aldosterone synthase inhibitors cause much more hyperkalemia than the new non-steroidal mineralocorticoid receptor antagonists. So I like them actually more than the aldosterone synthase inhibitors. But the aldosterone synthase inhibitors, from the data I've seen, reduce blood pressure much more than the receptor blockers. So maybe for patients with high blood pressure resistant hypertension, the aldosterone synthase inhibitors are better. And maybe for the other patients with a lower kidney function, the mineral receptor antagonists are preferred. Yeah. So this is perhaps how you can differentiate the two.
So still room for personalized medicine.
Still yes, a little bit, yeah.
Let's hear first. Yeah.
Yeah, question for you, Hiddo, but also to Christoph. Because all the drugs you have shown lower intraglomerular pressure. And then there's a patient with heart failure, there's a new patient, myocardial infarction, comes to the clinic, and then these cardiologists start all this medication at once. And I see that GFR drops from 80 to 40, and then they refer to the nephrologist. And the only thing a nephrologist does is taking off all these drugs immediately. Yeah, it becomes a little bit of a problem when all these medications work via intraglomerular pressure, or at least do something on intraglomerular pressure. Yeah. How low can we go there? Yeah. What's acceptable? And how do we do this in clinical practice? Because even when I know that I'm doing something good with GFR lowering with a new drug, when I've got a patient in my outpatient clinic, they come to me, they have a GFR of 60, and I start a drug and it drops to 55, and then I add the next one, it drops to 50, and then I add the third one, it drops to 45. They're starting to look at me, doctor, what are you doing? It was 60 a couple of weeks ago.
And Ron, and then you could say, and doctor, you always told me that I should care about my kidney function, and now you're starting treatments that reduce my GFR by 25 mils per minute. This is why I am not such a fan of that. Everything in 2 weeks, and let's do it, and it's so aggressive. I think we have to be careful and do it stepwise, perhaps over a longer period, in order to avoid that patients stop their medication and don't use anything. But Christoph, I know you have a different view.
This is a mathematical model. I don't think that it's true. Yeah? You assume, I assume, I think we need to test this. Yeah? To rule out that some people are afraid of this. And I don't think that it will happen. I only tested it in, I think, 2 I have seen, 2 patients. It didn't happen. You cannot add, and are you lowering always intraglomerular pressure to where, to 0, or what? I haven't understood this concept.
in the Rotate 3, where we tested eplerenone with SGLT2, the 2 drugs alone reduced GFR by 3 mils, and the combination reduced it on average by 7, but there were patients with a GFR decline of 15 mils after 2 weeks. So they started with 45, and then they had GFR of 30. It reversed directly when we stopped. So that was good. But I can imagine that if we are going to implement this everywhere, that there are people going to be super concerned.
So Hiddo, if you have a patient on a combination therapy of, let's say, 2, and you give a third, and there's no additional reduction in albuminuria, do you think that that third compound provides additional risk reduction?
If I'm 100% sure that the albuminuria level that I measure is the true albuminuria level. And I'm saying this because we always think that if you measure something, that is the truth. But there's so much variation that it may be a little bit more or a little bit less. And I've learned that from the SONA trial, where we only randomized patients when they had a more than 30% reduction in albuminuria. And then we thought these are the treatment responders. But then it turned out that the patients who didn't have a 30% reduction in albuminuria also had a benefit on the kidney endpoint in the long term. And probably our assessment is on the individual patient level is difficult to make. And there may be random variations that when we think there's 30%, on a population level it's 30%, I'm quite sure. Some have 31, some 29, and you average that. But at the individual patient level, it's very difficult. But if I'm sure that it is no reduction, I think that the chance that the drug is going to work in the long term is very small.
Thank you for your comprehensive overview, Hiddo. My question is kind of in line with the point that Mark raised. I must say I was a bit disappointed to see the data of the SGLT2 inhibitors that in the patients that don't show an effect on albuminuria, so the ones with the high albuminuria levels after initiation of SGLT2 inhibitors, that they didn't show any effect on the endpoints anymore. My question is, like most of my patients, they don't want extra pills. And in those specific patients where you don't see any change in albuminuria, let's say that's the true albuminuria level, do you think that I should stop the SGLT2 inhibitor in those patients and move on to other medication, or do you think that keeping them on SGLT2 inhibitors might get a synergistic effect by adding the other medication?
We should not forget that SGLT2 inhibitors also reduce body weight, HbA1c, blood pressure, uric acid, reduce the risk of hyperkalemia, reduce anemia, and have an increase in hematocrit. So if nothing happens, then I would stop. But you have to think about that these drugs also protect against heart failure. And so only focusing on the kidney is very good, but there's more than the kidney, and there's the heart as well. So be careful before you stop directly, I would say.
I thought in the graph you showed that also the heart failure endpoint also wasn't...
Maybe I did not explain this well. The residual albuminuria is predicting the outcome. So the level that is remaining. But it could well be true that a patient came from 3,000, was reduced to 1,000, and that patient has a big benefit, right? Because if it was stayed at 3,000, it would have a super high risk. So it's not saying that if the patient has a remaining albuminuria level of 1,000, the patient didn't respond, but because maybe the patient was much worse off without the SGLT2 inhibitor.
Hiddo, I'm a little bit concerned how the discussion is going. You are excited, I'm super excited, we are living in exciting times. We have something in hands, we do the new trials, but nobody is using the medication because everybody has concerns. And so how can we overcome this? Do we have to solve all these questions, do more trials? Do we need implementation trials? Who will pay them? And I'm a little
Yeah,
bit...
I think when we did the SGLT2 trials, we thought, okay, when we have the result, then everyone will use them. And we are a little disappointed about the uptake of SGLT2 inhibitors, although it is definitely increasing. And as Ron mentioned, these drugs are going out of patent this year, next year, and then I think more and more patients will get access to it. I think that there are many barriers for implementation, and I think that we should think about an implementation plan when we do these new clinical trials. We are writing many plans during a clinical trial, a statistical analysis plan, a project management plan, a safety management plan, etc., etc. But we should also write an implementation plan. How are we going to implement it? What are the potential barriers when we have a positive trial, and how can we overcome these barriers? One of the main barriers, I think, is finance, and that's difficult to overcome unless we change the whole healthcare structure in a country, which I hope I can, but then I would have a lot of power. So I think that's my idea about starting thinking early about implementation and do implementation trials.
And I think, Christoph, I should not be misunderstood. What I state is that you see a hemodynamic, reversible decrease in GFR, and that some people are afraid of it. But it is our task as nephrologists to know that it is beneficial. And what we are doing now, also when we have these heart failure patients, when we see it happening, we stop these drugs and tell patients never to start them again. No, the lessons that we should learn is that this is the thing we need. That is the thing that's actually is happening, but is beneficial. You can, of course, stop it temporarily, but don't forget to reinstitute it. So don't misunderstand me. I am very excited by the times that we are living in.
And don't measure creatinine anymore.
That I don't know. But
That's
don't be too afraid of it.
That's
Good point. Any other questions from the audience? Yeah.
CKD, such as in the renal lifecycle trial, are they excluded from the combination treatment trials? Because then we will need another foundation to
there's still room for
trial.
Piet Portman Foundation for the future, unfortunately, since most of these trials exclude dialysis patients or patients with a low GFR. And that is partly because of the reasons we just discussed. Suppose that in these combination trials you include a patient with a GFR of 15, and then you start a combination and the GFR drops to 10 or below 10. You're very close to the endpoint, and then it is possible that investigators start dialysis, and therefore the lower GFR patients are excluded for that reason. But perhaps we should also think about dialysis patients and aldosterone. Although there was a trial with spironolactone just recently presented that demonstrated no benefit of spironolactone on cardiovascular endpoints in dialysis patients.
So thank you, Hiddo, so much. I don't think there are additional questions.